Everyone, in today's video we'll be discussing about the integrated approach to respiratory distress syndrome, which will cover your physiology, biochemistry, embryology, pediatrics and obgy. So respiratory distress syndrome is also known as hyaline membrane disease. First thing, so respiratory distress syndrome, also known as hyaline membrane disease. Why so? So hyaline membrane is a pathological finding which you see in babies with respiratory distress syndrome, neonates more specifically. So when they saw the lungs of the baby in histopathologically, they saw that there is a hyaline membrane at the position of your diffusion where the diffusion of the exchange of gases takes place. So that hence it was also known as hyaline membrane disease. The other part is now we will discuss. So as you see on the left side, we have gestational weeks, how the lung was developed. So on the 20 week, which is the canicular, when there was a canicular phase of lungs, the surfactant production started, and on 28 week the surfactant was seen or it appeared in the amniotic fluid, and by 34 to 35 weeks the mature form of surfactant was formed. So to see what surfactant contains, we'll see on the right side. So you will have on the right side we have a type 2 pneumocyte, which is a squamous cell, flat squamous cells, and the major parts of surfactant is the surfactant which is dipalmitoyl phosphatidyl choline and surfactant proteins A, B, C, D, and also your mature form of surfactant which is there, it appears after the age of 34 to 35 week of gestation intrauterine, and that is one of the implication. So one application is that when you have to know the best test to assess the lung maturity of your baby is to measure phosphatidyl glycerol into the amniotic fluid. That is the best test. So we'll see what the other tests are. Other tests include a shake or a bubble test, which as you see that if the bubbles are present, this is the amniotic fluid, and you shake it, and if the bubbles are present, that signifies that the surfactant is present, which provides the surface tension. LS ratio is lecithin sphingomyelin ratio. So phosphatidyl choline is also known as lecithin. So more than lecithin, so more than 2 ratio signifies the lung maturity. Then you have the Nile blue sulfate test. So you take those cells of the baby and then you stain it, and if there more than 50% of the cells are orange, that is a positive test. So going back here, so you see that the mature form of surfactant is formed by 34 to 35 weeks. So any baby who is born preterm, like less than 34 weeks, will have respiratory distress syndrome or hyaline membrane disease. And the other form is if a baby is born term and there is a meconium aspiration syndrome, which could be a sign of fetal distress, and the baby aspirates meconium, that meconium mechanically deactivates the surfactant. So that could be one form of a term baby presenting with a similar mechanism as a respiratory distress. The other point is when you see the surfactant proteins A, B, C, D and the surfactant itself, so there are lipoproteins, and these are degraded by the granulocyte monocyte colony stimulating factor, that is GM-CSF, and that degradation forms metabolites which are thrown out of the cell. And if there are antibodies against the GM-CSF, which is seen usually in adults, in rare conditions in the adults, then there is a defect of degradation and clearing of the lipoproteins of the surfactant, and that leads to accumulation of those lipoproteins which inhibit the surfactant as well and prevents the diffusion of the gases, and that condition is pulmonary alveolar proteinosis. Okay, next point is, you see the physiology of surfactant production is that cortisol increases the production of surfactant, whereas insulin decreases. Both are counter-regulatory hormones, as you know. So how you can use this as an application in your practice. So first thing is, definitely if a baby is born less than 34 weeks, so that is 28 to 34 weeks. Why 28? Because in India we consider 28 weeks to be the period of viability, after which the baby can survive. And then at that time, so in 28 to 34 weeks, if a patient is going to go into preterm labor or anything, we are going to deliver the patient by an emergency LSCS. So during that, you can give the baby exogenous, the mother exogenous corticosteroid, which will be transmitted to the baby and the lung will mature. So dexamethasone and betamethasone are 2 drugs which are given and it needs 24 hours to act. Then on the opposite side we have babies, infants of diabetic mother. So diabetic mother will have high levels of insulin, and due to high levels of insulin there will be a need to provide high amount of glucose to the baby, and that high glucose stimulates the fetal pancreas and it increases the insulin amount, and due to that insulin increase, there is decrease in the surfactant production. The other point is unusual point is if a baby is born in 32 weeks and he's born from a mother of PIH who has suffered uteroplacental insufficiency, and the baby is a case of in utero growth restriction. So in these baby, the respiratory distress syndrome is less commonly seen because these baby are chronically exposed to stress, and that stress induces formation of cortisol, and then cortisol nullifies the effect of prematurity which is seen, and there is no outcome of RDS in IUGR babies. So how do you see where you will be encounter these cases? Okay, these cases are, for example, in modern obstetrics and pediatrics, these scenarios, most of the patients who take a regular visit and even have an uneventful delivery condition, they are definitely going to be given exogenous corticosteroids in form of betamethasone, dexamethasone. Consider a case of a villager or a female which is in a very less resource settings. So these patients, they hardly have any scans and they turn up into labor pains, and when they are turned up into labor pains and you see the USG that the patient is the gestation is low, there is going to be a preterm delivery, and you have very less time, and you have a main priority to have a proper delivery and a safe delivery, and during that period there is very less time to give surfactant, to give corticosteroid and prevent all these complications of prematurity. So in such cases, when the baby is born, what happens is there is tachypnea in the baby, cyanosis. On examination you will see retractions, which are the efforts made by the baby to bring more and more air, grunting, which is the noisy breathing, and during this period you will have two major scoring system. One is your Silverman-Anderson scoring, other is Downey scoring. Silverman-Anderson scoring contains all these 5 parameters which I have said: respiratory rate, cyanosis, retractions, which includes xiphoid retractions and upper and lower chest retraction and grunting, and Downey score as well similarly. So when such patients come and X-rays been taken on, so when you see the X-ray of these babies, you see that you will have a bilateral granular lung, which will denote a bilateral reticulonodular nodules there. Okay, and it will also contain air bronchogram and air in the esophagus. Next point is, so when you almost have diagnosed the condition, and more importantly respiratory distress in RDS patient present within 6 hours of delivery, and what treatment actions you have is, so you'll put the baby on continuous positive airway pressure, which is an NIV mode, or the non-invasive ventilation for baby, as you see in the image below. Okay, so what you'll do is you'll give positive pressure and you will prevent the collapse of the lung and the smaller segment, and after that you will give oxygen at a high pressure so that some amount of diffusion takes place. The other point is, when these scores, the Silverman-Anderson score and the Downey score, and the chest X-ray is very bad and there is a lot of involvement of the lung, so at that time you will have to give the baby surfactant exogenously, and these are surfactants are made from animals and then they are given. And the technique which is most commonly used is an INSURE technique, which includes, first you will intubate the patient, you will do an oral intubation as you see in the image, then you will clinically evaluate the tube position, you will give the surfactant via the T tube based on the doses, and after that you will extubate the baby and continue the CPAP which we have seen. This is in total about the integrated form of the RDS. If you have any question or any query, please put the comments below. Thank you.